Hi, everyone. Thank you for joining this Bertolotti Syndrome virtual meeting with Dr. Haines and Dr. Jenkins today. My name is Kit. I am the founder of this Bertolotti Syndrome platform, which I established about like 6 months ago. So far, I've been hosting these monthly meetings, and this meeting is very special because we have with us today Dr. Haines and Dr. Jenkins. For those who are at the start of their Bertolotti Syndrome, or who haven't heard of these doctors yet, Dr. Haines and Dr. Jenkins are like one of the few Bertolotti syndrome knowledgeable doctors, not only in the States, but in the whole world, I would say. So it's very, very special that they are here with us today. So thank you so much again. As for the structure of this meeting, I will be giving a short intro about Dr. Jenkins and Dr. Haines. After this, I did prepare a few questions so that we can go over them. But if you have any presentations that you would like to show, you can. We can also kick off with that. And then afterwards, there will be time for some questions in the Q&A. So if you would like to drop your questions in the chat, you can. So I guess a bit about Dr. Jenkins and Dr. Haines. I've looked in your past a bit. And so Dr. Jenkins, he's based in New York. He studied medicine at the University of Pennsylvania, and he has been a neurosurgery spine fellow also at the Harvard Medical School, and afterwards a neurosurgeon and a spine surgeon at the Mount Sinai Hospital for over 23 years by now. And next to this, he's the founder of Jenkins Neurospine, which was established 7 years ago. And on the other side of the virtual table, we have Dr. Haines. Dr. Haines, he is based in Virginia. He studied medicine at the University of Buffalo. He has done a fellowship at the Cleveland Clinic, and afterwards he practiced spine surgery at the Virginia Spine Institute for almost 9 years by now. And he's also the director of research. And you might have also seen him at Fox and ABC News, where he's educating others about having a healthy spine and maintaining a healthy spine. And both have received like multiple awards for best doctors year over year. I know this introduction, doesn't it doesn't do justice to everything that you have accomplished. But I think, we're all very grateful for you guys to be out there, because it's very difficult to live with Bertolotti syndrome and to go to, not knowing what it was to having now a solution, an answer from doctors like you guys who actually listen to us, and
New
have a
York,
solution for us.
I think so.
So yeah, thank you so much. And without further ado, I would like to get the floor to you. And would you like to add something to this and anything that you would like to share, Dr. Jenkins or Dr. Haynes?
Yeah, I mean, I know we want to have quite a bit of time for questions from the audience. Obviously, this is meant to be a partially an interactive talk. I would like to give a little bit of insight. You mentioned having doctors believe you. And I get it. Nobody taught me about Bertolotti's in medical school and residency and in fellowship, even early in practice. A patient walked in, said, I have Bertolotti's, and turns out he actually didn't, but he had the anatomy, and I started digging deeper into it. And it's still not, it's not, I don't, to my knowledge, not on the board. And there are even worse problems coming up. That I want to kind of run through a little bit. I'll try to run through this a little faster than I have in the past, if you guys don't mind, but it'll give you an idea of the history of Bertolotti's, why so many people have been gaslit with this condition for so long, and really what we need to do to go forward, because there are headwinds against us. There are storm clouds rising. And so I would like to, there we go. I would like to share my talk on the subject that I've prepared, and I'll try to get through it very quickly. And what this all comes down to, unfortunately, is that a well-regarded, excellent surgeon when he was very young, proposed his Castaldi classification. Antonio Eduardo Castaldi proposed this based on what he was doing during his fellowship in 1979, which was pre-MRI era. He was just looking for a way to predict disc herniations, not Bertolotti syndrome, disc herniations before they had MRIs. And so he came up with this idea that unfortunately, A, it didn't say the right things because it's not what he found doesn't reflect anything we find today with modern imaging. But B, it's been so widely misquoted, it's created more problems than it caused. And that's the Castaldi classification, the one that 9 out of 10 radiologists and doctors are aware of. But the reality is it's actually it's hurting you all more than anything else. And so we really need to abandon the use of the Castaldi classification. Um, just and I get no money for doing anything except seeing patients in spine surgery related to Bertolotti syndrome. But it's important to understand that these are real problems. You have real problems that have a real solution if you take it seriously. Now, this is my classification system that I developed similar to Castaldi, but really redoing it according to outcomes. Um, these are congenital anomalies. They actually develop in many patients, and sometimes this normal pathway gets a little bit blurred. And so instead of having a classic development, you may have a hybrid where you've got parts that are not quite according to the original architectural plans. And that can result in underdeveloped discs, underdeveloped muscle, underdeveloped facet joints, multiple congenital anomalies. In fact, not just the LSTV level, but at other levels as well. And it causes back pain. And it's one of the few conditions that causes back pain when you lie down. Not everybody has that, but many do. Many of you know what I'm talking about. But it's not what you don't know in life that gets you in trouble. It's what you know that ain't so. And many doctors think these can't cause pain because you were born with them. You'd have had pain from birth. And that's rogma. That's wrong dogma. It's not true. And now, we first heard about Bertolotti syndrome from Mario Bertolotti, who unfortunately wrote it in Italian, but it became a little bit better known because over the years, many people wrote about this condition. Unfortunately, the elephant in the room was this article. And I've read the article. You actually have to read the article as a scientist to understand all the things that were wrong with this article, and then read other people's literature as to how they misinterpret it to realize how you take two wrongs don't make a right. But these were well-intentioned people who had some bad ideas that should have been abandoned. But in this day and age, nobody makes retractions. But to be fair, Alf Nackhamson did issue finally a retraction. He admitted in the late 90s, or actually early 2000s, I didn't know the origin of back pain, and I don't know now. But unfortunately, what he did was he proposed that only discs could cause back pain. Therefore, any other problems in the back, and that includes spondylolysis, retrolisthesis, severe lumbar, all these conditions here, he did not think caused back pain. We know they do. There are thousands of articles describing how these cause back pain, but he was obsessed with back pain only coming from discs. And unfortunately, Antonio Castaldi followed his approach and said we were only looking for disc herniations with his classification system. All it was published, and it was just meant to look for disc herniations. And we know disc herniations aren't the problem in Bertolotti syndrome, but it resulted in Bertolotti syndrome patients. He was famous. Nobody wanted to go against him because he's now dead, and inertia. And people love to misquote him. This is in the radiology literature. They says they have no relation to what was initially described as Bertolotti syndrome. He didn't even say that, but they keep misquoting it. So instead, we came up with a new classification system. But what we've discovered recently, and this is important for everyone out there to know, insurance companies are using this misinformation to deny coverage for Bertolotti syndrome. Aetna, one of the three biggest insurance carriers in America, has issued this formal ruling. It's considered experimental to treat Bertolotti syndrome. They actually made this determination in February. They've revised their class. They deny coverage for Bertolotti syndrome surgery. And if you want to look this up, you can see for yourself. It's there. They put it in black and white. They've gamed the system because you can only complain about a coverage decision after you've been denied care. So no other person who's not an Aetna beneficiary can even complain to Aetna. And there's no basis for requesting for people calling in and saying, we think you're wrong, reconsider. There's no process for doctors to submit a challenge to these rulings. And they hire retired doctors, even spine surgeons, to parrot the party line of saying, I can't go against their determination. So in summary, radiologists and clinicians need to be educated to undo 40 years of rogma and teach people how to take Bertolotti's patients seriously. All treating physicians need to pool their data, like what Dr. Haines and I are going to start doing in the near future, to try to get to a better understanding so I can learn from what he's doing, and anybody else out there can learn if there's anything I have to share. Insurance companies need to update their criteria. This is not just an American problem. I see here patients from the NHS, from Canadian patients from all over the world come to me because they can't get their care at home because they're NHS, nationalized health insurances, typically will reduce what they pay for to anything they can put off. If they'll treat a hip fracture, they'll treat an acute MI, if you're under a certain age, and they limit care. That's how they maintain their limited pool of funds. And Bertolotti syndrome is one of the things they just don't want to cover. But we also have more questions to answer, and that's why people like Dr. Haines and I need to work together to really put out our good outcomes. This is how I look at it. I don't recommend fusions. I recommend fusions for type 2s. Not everybody does. This is my experience after doing my first 20 resections for this anatomy. I found they just didn't have good long-term results. And so because they have less muscle in this area, if you look closely, there's very little muscle in many, not all, many of these patients. They have these small discs, oops, covering them up, and they have these small facets. I just don't see that it's a long-term play, but that's something that I think is open to debate. And I'm looking forward to hearing what Dr. Haines has to say about how he looks at this condition very much. So in summary, my classification system that I use can be modified to take into account new things as we learn more about this. But I'm looking forward to working more with experienced doctors like Dr. Haines, as well as some of the pain doctors and other doctors in different specialties who are more Bertolotti's aware. I'm looking forward to educating Bertolotti's curious doctors because seeing is believing. But believing is necessary for seeing. If you don't believe in Bertolotti's, you'll never see that patient sitting right in front of you. And finally, improvements for treatments for all of our patients. So the call to action, get yourself to a Bertolotti's experienced surgeon, verify with your insurance that you'll get coverage, go through your HR representative, anybody who you get your insurance through, to lobby for coverage and for adequate coverage. And speak to your state and local representatives and senators because these insurance companies are regulated by the state governments first and national governments through the SEC and other publicly, regulated agencies. You can have a voice, and getting together and pulling people like from this audience is one way that we can have our voice be heard over the din of delay, defer, deny. So I want to thank you guys. I want to thank Dr. Haines for joining us, for KEM for putting this together and creating this platform, to the entire Bertolotti's community. to anybody who cares enough about their loved ones to be part of this conversation, and for anybody who can help us to fight the battle to get your voice heard. I also want to thank my research team and my patients. So my classification system is the QR code on the left. My outcomes paper. So just this is what we do. I just throw it out there, and you can look at it for yourself and see whether it makes sense to you. Is in the middle, and my Bertolotti's information page is on the right.
So yeah, thank you, Dr. Jenkins. That was an amazing talk, and I think that's something that's good for all of us to hear, and certainly myself included, to learn from, is the history of Bertolotti's and certainly your experience. So, you've been a tremendous assistant to so many patients. So I know we're all incredibly thankful for all your work and the discussion. I think you really hit on a couple very important topics. Is that the lack of curiosity, I think, in physicians. I still remember when the first time I heard of Bertolotti's, I was a fourth year orthopedic resident at a children's hospital, and there was a teen who showed up with a lot of back pain, and they were presenting this patient and said, "Oh, the radiologist said he's got Bertolotti's. What's that?" And the attending physicians were like, "Oh, that's not a thing," and moved on. And that was really the first time I heard about it. And I think that one thing that's important about Dr. Jenkins and myself is, that term would be medically gaslit. I think we see that a lot, and I don't think it's, I don't think it's because physicians are trying to. I think it's because the lack of curiosity. If someone hurts, there's almost always, if not always, but at least almost always, a direct reason for that pain. I still remember my first patient with this condition. Young, healthy person, skinny, in her late 20s, and she had a lot of terrible back pain. And we did this extensive analysis, workup, history, physical, all the things that we're taught as physicians. The common things being common: discs, facet joints, the SI joints, all these different kind of what we're taught in our training as the major causes of pain. They all looked fine. And then I saw, well, that's an enlarged transverse process. That's highly suspicious of Bertolotti's. And I had this sort of aha moment where, everyone believes, I don't think there's any debate, if you have bone-on-bone arthritis in the hip, it can hurt, right? You have bone-on-bone arthritis in the knee, it can hurt. Even in other parts of the spine, bone-on-bone arthritis there is pretty universally realized that, yeah, that causes pain. But we have this one artificial carve-out for the Bertolotti's joint. So we did an injection. After all the non-operative treatment, did an injection, and she pops up off the table and says, "Oh my gosh, I have no pain anymore." So for her, I know we're talking about the classification a lot. So she was a 2A. And with her, she was younger, healthier, and the next disc, the disc above the Bertolotti's segment, looked good. So I said, well, why don't we create a gap? And she's about 9 years out from her surgery, and actually just saw her back. She's had 5 children since, and her back still doesn't hurt. So it was this eye-opening moment for me where we diagnosed it in the way we would do every other condition. We treated it in a manner, and she's done really well. So I had this kind of aha moment where I'm like, I don't think there are a lot of people, doctors, myself included, and patients especially, who aren't getting the proper information, education on it. So I remember I did a quick little TikTok and just said, hey, ask your doc. Maybe if you're having pain, no one can figure out what it is, check out Bertolotti's. And it's been this amazing, awesome snowball effect where, both Dr. Jenkins and myself were really, really happy to talk to all of you and try to get the word out, because, both Dr. Jenkins and myself will have patients travel for us for this condition, but, we have patients who will travel for other conditions too. And I'll never forget, I had a patient who came from Calgary, skinny, healthy patient, for a simple microdiscectomy, a common procedure that's performed. And I was thrilled to help her out, but I also had this epiphany where there were a lot of doctors who could have done that procedure appropriately well, that she basically flew over to see me for. And I was very happy to help her out, but there were other doctors I think could. When it comes to this condition, that the community of doctors who can treat this is very small. It's become a very big mission of mine, and certainly Dr. Jenkins and a lot of other, and the other kind of inner crew of physicians who are treating this. It's an important message to get out, because, we have this feeling that if it's not us, then we wonder about, will people be able to get back to the lives that they're designed to? There are many different treatments, as we talked about, for this condition, and I think we'll probably delve into a little bit more of the why. I tend to trend more towards a resection. One of the things with fusion, we think about the adjacent level. So we're always, when we do a resection, we think about how long is that disc at the resection level going to last. When we think about a fusion, we think about what about the potential for that next disc going bad. In general, if it's an isolated Bertolotti's, unilateral more commonly, occasionally bilaterally, I'll do resections as well. Healthy disc above, I typically do a resection. If I decide that the disc above is painful, actually, fusions work extremely well as well. Basically, the analogy I always think about, it's kind of like the reverse Goldilocks. If there's just the wrong amount of bone, it hurts. So if you've got a gap in general, no rubbing and no pain. If it's fused together solidly, then also no rubbing and no pain. Just when it's that wrong amount that bone grinds on itself. So I think a fusion is a very effective treatment. One treatment I did this week for a gentleman who he had initially the right treatment from Canada, and the doctors in Canada did a fusion, but he didn't fully heal. So for that patient, he actually developed a painful disc above. So for him, we revised the fusion at the Bertolotti's and then did a disc replacement above. And he's 2 days out, but his old Bertolotti's pain seems to be gone already, which is really exciting. So moral of the story is I think there are both fusions and resections are very, very effective. I think it's for Dr. Jenkins and myself, we look very person by person and situation by situation when we define the two. And when we may decide one's a better option than the other. Ultimately, the big thing is just getting the information out. I think that the information area has been so profound in the management of not just this condition, but other medical conditions that patients are oftentimes not believed by their physicians about. So we're thrilled. Dr. James is a great guy. We get to partner together. We're working on future research. We have hurdles in the community, I think, are education for the doctors. I think that getting the word out to patients, and then as Dr. Jenkins really articulately put, insurance companies. Unfortunately, they seem to be coming for this condition, and it's not that, they're businesses. They try to save money. So even the more we can prove and the more of that as physicians, but especially as patients, as we get this outreach going, it's critical and huge for the bigger community. So with that, Kit, we wanted to save some time for questions. So is there anything in particular you would like to ask Dr. Jenkins or myself?
Yeah, I thank you both for, Dr. Jenkins for giving that presentation, and also the news about the Aetna. And Dr. Haines, thank you for commenting on the resection versus fusion. I have some questions that I prepared. We can go over it, and some of those you already answered. But I guess we can have an elaborate discussion, and then we can switch over to the questions. If I may share my screen. Let me see. Yes. Okay. So I have this overview. Let me increase. Can you all see my screen?
Yes.
Okay. So I guess Dr. Jenkins and Dr. Haines, you already went over it a bit of how, what was your first case. So Dr. Jenkins, you mentioned about the ROGMA. How can we change that? Like, what can we do in our lives for now to change the next generation? How can we make it easier for the people that are, the surgeons and also the patients about Bertolotti syndrome? What can we do right now?
Honestly, I think the best thing you can do is not try to find a way to get common ground with the doctors you're speaking to. Unfortunately, there's a lot of ego involved, and so you have to find a way to broach their lack of insight without making them feel that you're antagonizing or talking down to them. But I do know that having some published literature on the subject at least says, look, I know you may not believe this, but there are a number of people, and it's not I mean, I think there are, and I've looked at the PubMed graph. The amount of people who are publishing on the subject of Bertolotti's is exponential in the last 5 years. And so there are a lot of people publishing on this. You can even send them to Wikipedia or to other things because now they recognize it. If you ask Chat GPT, that recognizes this condition. And these are, there are ways to try to get around and say, look, you may not believe in this, but I do, and I would like to move on to the next step of making a diagnosis and potentially a treatment. And I'd like you to be part of that journey and invite them in, even if they're non-believers, to say, I'd like you to be part of this journey, and maybe you'll change your mind about it too. I mean, you want to engage, not alienate your caregivers. And they, like Dr. Haines said, they don't mean to be gaslighters. They were raised that way. They were taught by all the rogma that these can't cause pain. And why? Because it's a mental shortcut that lets them not think about it. They can move on to something else. They can shorten their differential diagnosis. You learn how to do that as a junior resident and intern, because when you're on rounds and you've got to get through rounds, if you have too many things on your list of what could be causing this problem, you want to have the bullet points that are key and ignore the chaff. You want to ignore the stuff that's not relevant. And, it's just this whole efficiency in modern medicine that drives people to take mental shortcuts. And you just want to encourage people not to do that for this particular condition. Why? Because the prevalence of the anatomy is so common. The likelihood is that many of these people will become symptomatic at some point in their life. This is a frequent problem, and it is a frequently overlooked problem, and that's what Dr. Haines and you guys, obviously, Temi and the work that she's done with the Bertolotti's Education Facebook group, and Kit, what you've done in such a short time in getting the awareness out through your website and your webinars is great. But it has to be viral, and then it also has to be exponential. You tell two people, they tell two people, each one of them tells two people. Next thing you know, we've got a pandemic of information and insight instead of, a zombie apocalypse.
Right. Um, Going back to what has been taught, like in medicine, like back in school, is that still the current, like the status quo, that a LSTV cannot cause any pain, or Bertolotti syndrome is not a real condition? Like, what's the current, perhaps Dr. Haines?
Yeah, it's not being taught much at all. I During my training, I really learned nothing about it. I know Dr. Steinmetz very well. He's a fantastic doctor, and he treats Bertolotti's at a high level. And I didn't do a single surgery with him actually during my training. We did lots of Bertolotti's surgery. I did lots of other surgeries, but even at Cleveland, when I trained there was 11 years ago, we weren't really seeing these patients that much, and we weren't really talking about it much. The training isn't there, so I think there are two major hurdles that we have. A major hurdle to physicians in terms of the accurate diagnosis. I think that really diagnosis with this condition is by far and away the most important characteristic of treatment. A lot of people, as Dr. Jenkins mentioned, have elements of this, but don't have so if you take their x-rays, they have an enlarged transverse process, may have a pseudoarticulation, but not everyone with those imaging findings has pain. And because of that, it's led doctors to say, oh, well, I want to look at an x-ray, and if that doesn't show me the answer right away, I got to move on. I think that some of the way that both and Dr. Jenkins, we like to practice is that's not our style of medicine. We can't be hey, see you in 3 minutes and walk out. I think the individualized care is critical. So there are a lot of hurdles in the medical community to adequately diagnose treat this and really talk to people like people. The other side, which I think that, Kate, you deserve a lot of credit for this, and the whole team, is the patient education. It's exciting that, with the information age, how we can get information out. And it's amazing how patients are so knowledgeable about this. I think patients in general are far more knowledgeable than the vast majority of spinal surgeons and spinal specialists. So getting the information out, sharing your stories is so critical. It always saddens me a bit that patients with Bertolotti's have to do so much of their own education, but I'm thrilled that the whole community is, because that's really what's allowing both Dr. Jenkins and myself to connect with you, to meet with you, and then also, and as well as other physicians, but to then also hopefully give you a diagnosis, a fix, and getting back to your life.
Thank you, Dr. Haines, for that explanation and your insights. Moving on to question 2 and 3, it's kind of like on the same line, and some of those you already answered. So how did you learn about these surgeries and about the resection versus fusion? Just in general, what is the best way for someone who has, who's experiencing lower back pain, some hints towards Bertolotti syndrome? What is the best way for them to get to a real diagnosis? So would you say I have heard one of your presentations before, Dr. Jenkins, about that the CT scan is the best imaging method to see the LSTV as compared to an MRI or as compared to an X-ray, because of the oblique view that makes it complicated to view it. So would you say you would direct your patients to a CT scan first, or would any scan be sufficient?
Well, I think the issue really comes down to it's in the details. The MRI can be fantastic for making the diagnosis if they do the coronal, which many MRIs don't, or if they just go far enough out laterally with the sagittal images to look at the transverse ala interface, which most of them don't. X-rays are great for looking at this anatomy if done at the right angle. There's an angle called the Ferguson view. It's widely known. It's been around for like 100 years, but it's not part of the routine angles. There's an AP, a lateral. There's often a spot L5S1, but there's no routine use of this Ferguson view. So when I order X-rays, anybody who's had an X-ray ordered by me knows we ask for 5 views. Okay, we ask for the AP. I don't ask for the L5S1 spot. We ask for the AP, the lateral, the Ferguson view to look up the disc space, and then the flexion extension, because most patients with a type 2 or higher LSTV don't move at the LSTV level, but the ones above, the type 1s typically do. And so, but it's also critical to look at the level above, as Dr. Haines has said, because it's been shown, even using the outdated Castaldi classification system, the incidence of having a problem at the level above, de novo, without any surgery, is 40% if you have an LSTV. And so I suspect it might even be higher if we included the 75% of type 1s that fall out of Castaldi that are symptomatic but not even classified as having an LSTV by Castaldi. And so it is critical for you to look at something that looks at the imaging. CAT scans are great because I can reconstruct them. Even if they don't send me the reconstructions, I can do it on my own. And I can look at how are the bones, how close are they, are they touching, what's the nature of that interface, what's the size of all of these things can be done, and they can be done with any images. And we're trying to get the medical community to be more open to, if they do an AP and suspect that there is an LSTV, to realize there's a reason to do that Ferguson view. Now, most X-ray facilities are looking at, well, we're only going to do what's ordered because we're only going to get paid for what was ordered. And so even doing one extra view slows down the tech a little bit and exposes the patient to a minuscule amount of radiation. So their argument is benevolence, but the reality is it's probably cost and time. But we have to show them that these are valuable images and they do help us to make. So you can get a really quick Ferguson view in an ER and you'll know right away, do I have an LSTV? Could this be part of my pain?
Mhm. Dr. Haines, do you have anything to add onto this?
I agree with that. I have a model of the spine, and essentially, when we take our X-rays normally, a straight AP or the straight-in shot goes like this. Like Dr. Jenkins says, well, it's usually tilted down like this. So if we shoot straight this way, we get a very obscured view. So that Ferguson view is looking straight on like that. That's really the critical picture to see the joint well. A big thing that, CT scan is a wonderful tool. The MRI gives us some information on the Bertolotti's level. It also very importantly helps look at other conditions. I always get an MRI to make sure there's not another disc issue going on. There's no swelling in the facet joints or the joints in the back part of the spine or some other obvious cause of the symptoms. And then a big thing is the diagnostic injection. I think we're both very dogmatic about making sure that we get a lidocaine injection in that joint. It's that functional piece where if someone has a lot of pain and you inject a spot and the pain goes away, that's the bullseye. So that's something that I'm a big believer in, is that diagnostic injection to practically confirm that that's where the pain is coming from.
Yes. Along this line, when someone goes for diagnostic injections, it can still be very tricky depending on the person who will inject the lidocaine in the right locations. I know, Dr. Jenkins, you always draw, on the image and saying exactly where to inject. But, in reality, it can be maybe just a bit next to it or even not, in that location. Do you refer your patients to certain locations where injections have been done correctly before, to also, again, reduce the time for the patient in getting the correct diagnostic outcomes? Do you have a kind of like a database for that, or do you refer to certain locations?
I have a few that I work with regularly locally. I have tried keeping a database of practitioners who do injections that have had good outcomes. And unfortunately, I've also then had bad outcomes from those same practitioners when the next patient went to them. And so I've gotten out of the habit of trying to refer to, but I will also say that of the maybe hundreds of patients that I've seen, I think we're getting close to 1,000 in terms of consults given, is 70% of the doctors who pay or for patients who come to me for surgery were injected locally by somebody at home with the guidance that we give. But the key is they have to inject, just as we talked about, the Ferguson view is looking from down to up because the image, the source is actually in front of the patient. The injection has to be done at a very down angle, starting higher in the back and aiming down into the LSTV, because that's the interface of the contact when you have a type 2 or higher LSTV. And so if your contact is at this angle and you come in at this angle, you're not going to get into that angle down here. And I've had anesthesiologists and radiologists who do CT say you can't get there from here. I'm like, what are you talking about? It's just a straight line. You just have to take a longer needle and come down at this angle. And then I always demand the screenshots, because whenever they do them under X-ray guidance, the first thing they do is they inject a little dye to show where the tip of the needle is in the body. So you can see, is the dye in that interface, or is the dye just kind of spreading on the surface? And if it's not in the interface and they have a type 2 anatomy, I'm like, and you didn't get relief, that's probably the reason. But ultimately, the LSTV injections are probably the most sensitive and specific injection we have in the practice of medicine, If you get a relief from that, it's almost never anything else. And so it's, as Dr. Haines has said, that's a critical part of the diagnosis, getting it done right, but confirm. I'm a trust but verify kind of guy. So confirm with the screenshots that they were where they said they were.
Mhm.
Yeah, I agree with that perfectly. You know, this is an injection that not everyone can do, and it certainly has to be with someone. Yeah, trust but verify is a wonderful term. We say that a lot in medicine, and I agree with that 100%. Um, I, I will say this is kind of occasionally annoying for patients. I know one really gives me a pushback, but I do the injections myself. Just because, like Dr. Jenkins said, it's a steep angle. The LSTV is like this. One thing I always tell patients, like, it's not a straight in shot. So I always kind of remind them, by the way, this is going to feel that where I numb up is going to feel a whole lot higher in your back than where it ends is just because of that steep angle. So yeah, this is a procedure I do myself. So a common scenarios, someone comes in, you know, after we think that they do have a painful Bertolotti's joint. And on that same day, I typically, especially because a lot of people do travel to see both Dr. Jenkins and myself, typically that same day I do an injection and then road test it. So I had a patient on just yesterday on Friday who is a high level softball and basketball player, and it really bothers her back when she swings a bat. So we had to go down to our therapy office, get one of the bats, and do some swings. It's funny, it's softball again, but I had someone who's another high level softball player, and it bothered her when she was pitching. So the road test for her was in front of my office after her injection. She went and pitched with her dad. Um, I like to do that diagnostic lidocaine injection, and then it's game time to road test it. The injection's not going to last, you know, 3 days and maybe 3 hours though. So during that first moment, I like to see what sort of relief people get. And I really want to be pretty dogmatic about making sure they're doing the things that do bother them.
Okay. Wow. That's great information, actually. So continuing on that line, so after the diagnostic injections, let's say it's confirmed that one has a Bertolotti syndrome, um, and then comes the option of having a resection or fusion. So it's great to have you two out there. But to be honest, for us, when we have to make the decision, it's very difficult because we get these, great advice from you two, but then it's like kind of like a hard decision to choose one over the other. Um, Dr. Haines, you have done a lot of resections. Over time, how do you deal with like the different techniques for your resections? And for example, do you put bone wax? Do you see bone regrowth? How do you deal with, patients who have an extra vertebrae? So the L6 patients. Do you recommend doing fusions instead? And do you work together with Dr. Jenkins? To maybe provide the best outcome for the patient. How has that been for you?
Sure. Yeah, my general thought process is, you know, were me, I'd prefer to have a resection. It's and you know, and this is an area that Dr. Jenks and I both clearly he's an expert. We're working collaboratively together to learn from each other. I tend to do resections more if it's unilateral. Um, if it's a deep-seated, if it in general, if the level is very deep-seated, we tend to think it's a little more protected by the pelvis, so I feel even more comfortable in those scenarios. The discs typically are somewhat rudimentary when someone has a Bertolotti's condition. So because of that, on one hand, we think, well, is that disc going to last 50, 60 years, where the length of time we're hoping for? On the other hand, because of the congenital nature of this condition in most patients, that disc has never really had to work hard. So it's kind of a double-edged sword. It's never had to work before, but it's also never had to work, so it never fully developed. I've been doing this for, and certainly time will tell as time goes on. Just my first Bertolotti's resection was approximately 10 years ago, and the one who came back and hasn't had pain. So I haven't seen that disc wear down yet on any of my resections. I did have a patient who we did a resection at the Bertolotti's level, and she had a somewhat degenerative disc above, but it was very like it was not painful before surgery. Then we did the resection, and actually, I would think that should preserve the disc above, but she actually then developed some disc degeneration at the level above. And and we did a disc replacement, and she's in the early healing phase, but is doing very well. So typically unilateral, if the adjacent disc is healthy, I'm pretty much doing a resection. I've done some bilateral resections and maybe higher level athletes where we're trying to hold off on a fusion. A common scenario that I do recommend a fusion. I know I'm chatting with with one person in particular, and there are a couple of patients who've had that condition on this chat right now. But is when I do a disc replacement adjacent to it. So if someone has a painful disc at the level above the articulation level, there are a couple of different options. One of the things that I actually do a lot for discogenic pain or disc-related pain, um, irrespective of a concomitant Bertolotti's, is a stem cell injection. That's a potential wonderful non-surgical option. Usually, if we're doing a treatment on the Bertolotti's level, we're looking at the disc above anyways. I typically do an anterior approach for the fusion at the Bertolotti's, and then typically a disc replacement at the level above if that's been defined as a pain generator. When it comes to disc replacement, there are a lot of qualifiers, so that's probably a whole nother talk where there are a lot of potential reasons why someone is a good candidate for disc replacement, why someone may not be. So it's not a universal law, but I would say if someone has a painful disc above, I actually do like doing a fusion in the disc above because then it's one incision as opposed to a resection incision plus a disc replacement incision.
Yeah, so those are all great points. I agree 1,000%. I would rather have a resection than a fusion if I thought it was going to last. And this is also why it's great for us to compare notes and to discuss and to learn from each other. As I said, when I looked at my early experience with resections for type 2 anatomy, I just didn't see the great outcomes. And so most of the patients, I have this discussion. I say we could do a resection with the knowledge that in my hands, there's a greater than 50% chance you're coming back for a fusion later. And if we're coming back for a fusion later, we've already resected the bridge of bone that I want to actually create in the fusion. And because I've created this fusion procedure that's an outpatient procedure, most patients that I have this discussion with agree, let's just do the fusion. The disc, the LST level isn't moving now, and I'm okay with that motion. Therefore, I'm not really losing any motion by doing a fusion. I'm fusing across the level that looks like it was trying to fuse in the first place, and I'm just finishing what nature started. But there are a few patients that we will say, let's give it a shot and see what happens. As I said, not all of my patients came back for surgery. I have one patient who we actually called him up 5 years later for our routine follow-up, and he's like, "Why are you bothering me?" I'm like, "Well, how's your back feeling?" "It's great. Why are you asking?" I'm like, "Good talk. Okay." So, there are many patients who do well, and I would love to do more resections as long as I have the confidence that the long-term outcomes will, and this is where Dr. Haines and I can discuss and I can learn from him. But in terms of figuring it out, for me, it's type 1s get a resection, type 2s get a fusion unless there's a reason not to. Type 4s, we do a unilateral fusion on the open side, which almost always solves the problem on both sides. And it seems somewhat counterintuitive because many of them are painful on that one side, the side that's already fused. And they're like, but why is it hurting me if it's fused? And the answer is because it still has open disc, open facets, and you're flexing the other side. You're stressing, you're basically developing a stress fracture at the side that is fused. And sometimes the CT fools us and it looks like it's fused, but I get in there and it's actually not fused. So there's a number of reasons why these things do play out, but it is a patient by patient basis. It is a decision. It's a conversation that we have as to whether this is the right for them. And especially for many of the patients who are coming long distances, they're afraid they're not going to be able to come back a second time. They just want to be one and done. And to me, as I said, here's the funny thing. We talk about in spine surgery, if you fuse a normal disc for good reasons, let's assume that the indications are solid, they needed to have that level fused, and it was normal anatomy to begin with. We talk about a 20% incidence of the adjacent level breaking down, 20% requiring surgery down the road at a later time. we already mentioned that there are multiple studies that show up to 40% incidence of having an adjacent level problem. And as Dr. Haines said, about half of my patients that I wind up operating on, I wind up operating doing something at the next level. Maybe they have a disc herniation. Maybe they have a second level of LSTV where they had type 2 at L6S1 and type 1 at L5, L6, and they're symptomatic there. Or they're so badly broken down, they already have a massive mobile slip at L4-5 with a 5-1 LSTV, and we would fuse both of those levels. So there is a spectrum of what I call Bertolotti's plus. But what we have found in our series is that even if they have a non-painful anatomic problem at the level above, we've done an epidural, we've done medial branch blocks, we've done other treatments to see, let's call it 4 or 5, is the 4 or 5 level generating your pain? And if the answer is no, even if they have a slip, we just treat the 5-1 level. And even with the fusion at 5-1, there's only about a 5 to 10% incidence of that next level getting worse, because it's not actually adding more stress to fuse a level that was never moving to begin with. So it is what it is. It's complicated. It's patient by patient. It's a ground war. I get into the trenches with every single patient to figure out what each one needs. And so while I have these guidelines and these rules, there are times that we'll go off the menu and do something that's very patient specific.
Yeah, I want to jump on one thing that Dr. Jenkins just said that I think is 100% spot on, that I've been fooled on, that I've learned lessons on, is, we think that if it's completely fused, that one of the sides is completely fused, that it shouldn't cause pain, and a CT scan looks like it's not fused, and we do an injection and all the pain goes away, and I'm scratching my head, at least early on, and we realize even though everything seems like it's fused, you get this force transfer, you get pain on the other side. And oftentimes there's just, like you said, a potential for stress fracture or even maybe some of the plastic nature, some deformation of the bone that's causing pain. Situations that I've been wrong on, that initially I look at the CT and say, oh, it's fused, that shouldn't cause the pain, and then the injection just tells us differently, and so does the treatment.
Mm-hmm.
Yep.
Do you have any comments on surgeries done from the front, so like anterior versus from the back? Or do you only do those that are, coming from the back?
Sorry, Kid, was that for me to start, or?
Why don't you go ahead? Because
Okay.
I have strong opinions on this. So why don't you go ahead?
This will actually be a good one, because I typically do an anterior approach. There are some risks with it, but I typically do an anterior approach for this. In general, I do more and this is in my hands. I tend to find that when there's more of a risk of muscular disruption going through posteriorly or through the back, one of the things that I see in my hands is actually the potential for those screws to cause some physical pain there, or SI pain nearby. So oftentimes I'm removing the screws. That being said, so my bias in general, I'm much more anteriorly based surgeon. To avoid those things, I will say that there are some risks with it. And this is especially when there's a level that's been, when someone has this painful transitional anatomy, I think that the spine has been more fixed in that position. And there are many times they're doing a fusion. Well, actually, I have a model. This is the type of fusion I do, an anteriorly based through the front. So that's a cage that puts a separation and gets bone to fuse through the middle. There are many circumstances where if someone has a spondylolisthesis or slippage of the bones causing nerve pressure, where we really want to distract and open up that space. And this is one of the conditions where we definitely don't, if you're doing anteriorly. It can irritate the nerves. You can get definite postoperative nerve tension. And one of the downsides of doing anteriorly is that the space is usually smaller. So if you have to stretch it out, there's a little bit more risk to that. I use very small, very narrow implants, but that's a lesson I've learned, because you don't want anyone just shoving a cage in there, because that can cause a lot of nerve symptoms.
Yeah, no, those are all great points in there. Certainly points that live by what I do. So for me, when I'm doing my fusions, I've actually seen patients come to me for second opinions after having a full, beautiful fuse on CT scan, anterior fusion, and they still have their Bertolotti's pain. I think there's some kind of plastic deformation still going on. And I went back and I just did a posterior onlay fusion. Didn't even have to put screws in. I just dropped bone graft in and the pain went away. So to me, the point you make about it's an hypoplastic disc to begin with, if they have height, because not every patient does. I've seen plenty of patients with Bertolotti's who have a tall, normal size 5-1 disc. What's interesting, and I'm sure Dr. Haines, you've seen this, is that there's so much of the literature on the normal anatomy of the disc height. They include that most of the time the average L5S1 disc height is smaller than the 4.5 and the 3.4. Why? Because they're including LSTV patients in their normal patients. They didn't, because it's so common, they were afraid to eliminate them. And so what I have found is that the average LSTV patient has a disc height at 5.1 that is 70% of the height of a normal. Some are 50%. So that means you've got a tiny little disc there that I just find it's difficult to get either from the front or from the back an inner body cage into that space. And if it's already so small, eventually that disc will fuse. I will also say that if you have 6 lumbar vertebrae, the odds are that L6S1 may be angled so far down that it's below the symphysis pubis. So it's actually very hard to get to from a normal ALIF approach. And I'm sure Dr. Haines is aware of those and doesn't recommend those for fusion unless he's got a very good approach surgeon who can get them around that corner. But that's just some of the things that I see. So for my routine, and as I said, I have this MIS posterior outpatient procedure for fusions that works. 90% of my Bertolotti's fusions are done where the patient does not spend one night in the hospital. They leave same day. And we will not comment on what people say on the internet about their postoperative day 1, day 0 recovery, because it's a spectrum, and some people are in miserable pain and some people are in no pain, and everyone's different, and you can't expect anything other than that we'll do their best to manage it.
Thank you. So moving along to the next questions, I think we covered it all. Also, thinking about the past, what has been taught, and also what can be changed. So I guess going to the last part of this, Dr. Jenkins, I've been following you on LinkedIn, and Dr. Haines, I've been following you a lot on social media and on Instagram. It seems that you're very passionate to get the word out there. So I think I can speak for the whole Bertolotti community. We are very grateful for you. Isn't it frustrating when you're in a clinic, when you're seeing other doctors, when you're at meetings and you're trying to educate, but then hearing someone not being open to it? How do you deal with that?
I very often, especially at some of the big meetings where I've had a chance to present, I'll say, let's see a show of hands. How many people here know transitional anatomy can't cause pain? And I'll see people who will raise their hands. And I'll say, how many people, I will say, the patients are seeing you. Are you seeing them? And so I'm just kind of pushing back and I'm challenging them to recognize and to be open their minds to the possibility that the rogma that they've been relying on is, it's a castle built on sand. It's really not a stable ground to base your clinical decisions on, and that you need to use evidence-based medicine. And here's the evidence. I teach my residents. I give talks wherever I can. And I think the most important thing that we as clinicians can do is to question everything. Just question the evidence. Make sure that that what you're basing your decisions on is evidence-based and not just what your mentor told you once and that you've taken that to heart forever. You don't have to be loyal when it comes to your patients. Your loyalty should be your patients first and your mentor second. But our mentors are how we all got to where we are. So it's not to discount it, but it gets back to that whole trust but verify mentality of trust your mentors, but verify that what they're saying is evidence-based and not just what his mentor taught him without presenting the evidence for it. And as I said, if you want to see the value of that, read the actual Castaldi article and realize there's a lot of not great literature out there. And in this day and age, there's even more not great literature because many of these journals are for-profit entities where they're encouraged to publish anything because then they get fees for publishing.
Yeah, I certainly agree with everything you said. I think that, I've spoken on this or some other conditions that some physicians think of as controversial, and it's always funny because Dr. Jenkins and I will be speaking on the podium, and in public, doctors will give a little resistance, and then they grab you after, and when you step off your talk, and they say, "Boy, I got this patient, and I think that's it. I just don't know what to do with it." And so good to hear you talking about that. Can you give me some advice? And that's a common thing we hear, that doctors are interested, but it's you have to have a specific type of clinic, I think, to and an interest to help patients with this. I think that we're all, Dr. Jenkins and I, trained at in my opinion, very, very good institutions. I love my training, I love my mentors, but I don't think I could really probably practice the medicine the way that I think we need to in that sort of setting. A lot of times, it's just the way of conveyor belt healthcare, where you're told by administrator you got to see 10 patients an hour and in and out. And that's just not how this condition works. One of the things, talking about fusion specifically, you heard Dr. Jenkins and I talk about the subtleties and the intricacies of fusion and talking about how deep-seated it is in the pelvis. It's so exciting to be able to talk about this with him and have you guys hear this, because most places say, "Oh, fuse the bottom level, just fuse it," right? We're not thinking about all the intricacies that come into play. So, we try to teach, we try to educate, and then importantly, we talk about these nuances even with doctors, because the standard doctor is not thinking about all this when it comes to treatment of this condition.
Thank you. So as for the last question that I have, do you have any last words or advice towards the Bertolotti syndrome community?
Never, ever give up. You are your own best advocate. And don't be afraid to go through intermediaries to help you get where you need to go. Find back channels, but also, be an advocate, have a voice, like Kit has done, and create a platform for discussions. But reach out to your state representatives, reach out to your state senators, reach out to your elected, federal, your congressmen and your senators. Let them know that you are being, that this is an area that requires more awareness. They don't know. And I've tried teaching them as well. And it's just, they have a certain amount of bandwidth. And, for example, when it's budget season, when it's campaign season, and when it's this season, it's that season, they're focusing on what they can, but find ways to just have your voice and make your voice heard without sounding like, you're a crazy person. And that's a challenge, but it is, I know that, by being a doctor who treats a lot of poorly understood conditions, there are a few doctors out there who think that I'm not mainstream and that I'm, one of those wackadoos who listens to his patients. Yeah, I'm always going to choose that over conformity, because my patients have taught me more than most of my faculty and senior residents ever did. So, it's listening takes time in as Dr. Haines said, this efficiency geared medical factory system, but efficiency is not the most important. Outcomes are.
Yeah, great sentiment, great words, and I certainly agree with you. This is, unfortunately, it has become, because I think of lack of overall medical knowledge and insurance challenges, this has become a condition that patients self-educate a lot on. I mean, it's really without technology like this and different forums and web pages and WebExes and webinars, it's very hard for patients to find the stories that really propel us to get people feeling better and the stories that give people hope. I think that, there was one comment earlier that said, I have chronic pain syndrome, and we have Dr. Jenkins and I treat a lot of patients who have chronic pain syndrome that get fixed with a procedure, and it's because they didn't have chronic pain syndrome. They just had a condition that they got mislabeled on. I think that chronic pain syndrome, and there are true syndromes, but I'd say the majority of them end up being the doctor didn't know the answer because it didn't fit the textbook on chapter one. So they got labeled chronic pain syndrome, and then that's kind of a scarlet letter that patient carries with them unfairly. Um, Keep digging, keep searching, keep communicating. And, I certainly mean this from the heart. Dr. Jenkins is incredibly knowledgeable and skilled on this. I like to think that I know this condition pretty well too. So search and reach out to us and reach out to each other that keep up with the good fight.
Thank you, Dr. Haines, and also thank you, Dr. Jenkins, for all your, insights, information, for being here in our call today. This has been very helpful, I think. I just went through the chat and we have many, many questions. So I am not sure, well, I probably don't think we can go through all of them. I see that Dr. Jenkins, you did respond to a couple of them. I guess since it's so many, would you like to go through some of them and pick out the ones that you would like to respond to?
You know, here's one that's actually very near and dear to my heart because I have done this a few times and it is a thrash. Can CCI and Bertolotti's be fixed in one surgery instead of 2 different days? Yes, but it's a miserable experience. And I've only done it when I've had patients who were so severely disabled that they couldn't recover from one procedure adequately without doing both. For those who don't know, CCI is craniocervical instability. Many patients with Bertolotti's are also hypermobile. When they go like this, they can push their thumb much closer to their forearm than I can. And that's just one of the many markers that's on the Beighton scale as well. That's a way of measuring your degree of hypermobility. And Ehlers-Danlos syndrome hypermobile type is one type of hypermobility. Those patients can have excess movement at their head, and where actually we wind up stretching the cranial nerve, the vagus nerve, which runs with the jugular vein, and the superior cervical. The point is, this causes dysautonomia. It can cause brain fog from venous backup at temporary increased brain pressure. It can cause all sorts of other physical symptoms that may seem completely unrelated. Abdominal pain, perineal pain. The symptoms that I have seen improve with treatment of these conditions are shocking how broad they are. But it's a big operation for one, and it's a big operation for the other, and they hurt, and that means you're doubling up the amount of pain. You're doubling up a brace in the neck and most likely a brace in the low back. It's a lot to recover from. So it is not recommended. But, once again, you got to get in the trenches and you got to see, what it is. Because as I said, 50% of my patients who come in with one diagnosis have more than one diagnosis. To that point, I know I've seen it in the Bertolotti's education group, the discussion about how many patients come to me and they walk in with, I got Bertolotti's, and I look at them and I say, yeah, but you walk like a drunken sailor. You probably have cervical myelopathy as well. We find out, and we may treat the cervical stenosis first, and then they get better with their low back symptoms, and that's great. But frequently, and I'm sure Dr. Haines would agree, spinal cord level problems typically trump non-spinal cord level problems. And so we will usually do that first unless the symptoms from one are so benign, we think that there is time to wait and reevaluate until later. So it's this whole, what is associated with Bertolotti syndrome, congenital cervical stenosis, Chiari malformations, tethered cords, other transitional anatomy like cervical ribs. If you are likely to have a misalignment of your spine in the lumbar spine, you probably also have ribs that are not quite normal either, because that's a transitional region as well. So I look at the whole big picture. So every patient who walks into my office gets a full evaluation head to toe. But some are more specific than others, because once you find one symptom that kind of piques your interest, you dig a little deeper.
I know there are a ton of questions on here. One of the things, and we didn't talk about it a ton, was non-operative treatment for this condition. I think Dr. Jenkins and myself both see a lot of people, and probably largely of you, who have been really saddled with this condition for a long period of time. The nice thing about most of patients we see, 9 times out of 10, we get them better non-surgically overall. One of the areas that ratio just isn't the case is for Bertolotti's for me, and it's a lot of times it's because people have already done all the injections and already done the therapy and the diagnostics. A couple of potential options, and it's very transparently, I've not seen a ton of long-term or even midterm success with it. So if someone has an injection, usually it's up with cortisone for symptomatic relief. People can get some relief, but it tends to wear off. Not all the time, but if it's really symptomatic Bertolotti's, typically it does. A couple of backup options. Sometimes people talk about regenerative medicine, PRP or stem cells as an option. Usually it's a little more PRP that I hear about. Largely because PRP, it's not quite an expensive procedure. Insurances don't cover those, like no one's do, unfortunately, whether it's stem cells or PRP, which the body's growth factors. The stem cells are the cells that grow into stuff. Largely, I think intellectually it tends not to work because you already have that bone-on-bone arthritis, right? It's grinding, it's already painful. So the non-operative treatments, or those regenerative, haven't worked terribly well. One that is a reasonable option, but I also similarly just have not seen good mid to long-term results with it, is a radiofrequency ablation. Essentially, it's a heat probe. So you stun. It's a common thing done for facet pain, which is pain in spine, these joints in the back. Um, it's a reasonable option to try for Bertolotti's. I just haven't seen that be successful. So usually when it gets to the point of, hey, I'm miserable, it's not working, tends to be more of a surgical correction. If it's more earlier on in the process, that's when PT, cortisone injections, maybe a radiofrequency ablation can buy some time until it progresses.
Yeah, my experience with ablations is they work at all half the time, and they work for a durable period almost never. They usually wear off. Like, ablations are an actually pretty good way of dealing with facet-mediated pain for up to 3 to 6 months of relief. But for Bertolotti's, it's almost always very quickly gone because it's a bone-on-bone problem that doesn't go away. So the nerves either regrow or become painful again very quickly. And it's also not a typical, most of the pain docs aren't used to where those pain fibers are coming from. So Bertolotti's can be managed conservatively until it can't. And that's the problem. Once it gets to the point where it can't be managed with anything else you're doing, then yes, surgery is the next step. So not every patient who comes into my office with Bertolotti's gets an operation for Bertolotti's, because sometimes they're just not ready and they just want to know, what are my options? And when I explain to them the options, they're like, well, I'm not ready for that. I'm like, okay, great. Great. That's fantastic. Because when you are ready, you will know. And so it's a patient by patient evaluation.
Thank you, Dr. Jenkins. I guess maybe because of the time, let's maybe move to two people who have their hands raised for any questions. Maybe Matthias, if you would like to pose your question.
Hi, thanks, Dr. Haines and Dr. Jenkins for coming today for this conversation. It has been very useful. I just had two questions, one on the diagnostic side and one on the surgical side. On the diagnostic side, what are the common congenital findings that you have seen to find with Bertolotti's? Typical thing, at least from my review, is EDS, as Dr. Jenkins mentioned, as well as an extra L6. Are there other things that you have found, and is there a genetic underpinning that you think could be at play here?
So I can say that we've looked into genetic underpinnings. We are in the process. We've actually applied for funding and have not gotten funding to actually run a clinical trial of doing genetic analysis of all of Bertolotti's patients. So that is something we keep coming back for, looking to get funded. We do believe that there are genes like the MTHFR gene and others that may have relationships with congenital anomalies. But as far as the congenital anomalies, most common is actually the congenital cervical stenosis. So that's a common association. It's not clear that it's causative, but it's clearly associated. Second one is actually a spina bifida occulta, where the spinous processes in development didn't form properly, and there may be a gap there. And I've even seen some Bertolotti's patients who have a floating spinous process in between their two laminas that's disconnected, and that when you bend backwards, that pushes the bone back into the nerves. And I've seen patients with back and pelvic pain from that. I will say that the treatment for that condition is not to do a transdural stem cell injection into that disc. Yeah,
Don't do that.
And I've seen it done. That's why I can say it. That's not
Yeah.
That's not the treatment. But anyway, so I had a patient who actually had that and then needed a CSF leak repair. Okay. But the point being that that there are many congenital anomalies, and I see, especially if you have hypermobility, then you've got this whole spectrum of hypermobility related conditions like CCI, thoracic outlet syndrome, popping ribs, and there are just you just have to look at that pain diagram and take your time and go through. All right, what's this pain coming from? What's this pain coming from? What's this pain coming from? And just do it and it just takes time.
Mhm.
And it just, you got to look at the whole spectrum of congenital anomalies and just keep an open mind.
So the thoracic outlet syndrome and CCI are typically just, let's call them subsets of an EDS, a patient with EDS, not necessarily independent of EDS. So you won't see thoracic outlet syndrome in someone that does not have EDS,
Oh,
generally speaking.
you absolutely can.
Oh,
Because
okay.
you get thoracic outlet syndrome from injury to the shoulder and from other conditions as
Yeah,
well.
I mean,
So,
congenitally, from that, generally speaking. Okay, no, that is very helpful. Thank you very much. My second question is the surgical approach. There have been a few papers that have been published by international doctors as well as the US. When they're approaching resections, they have tried to do the resection of the transverse process, but at the pedicle. So basically, they're disconnecting the transverse process from the L5 or like the last segment, and just basically like just clipping the wings. My assumption is that both you and Dr. Haines do not think this is a best approach, but it would be great if you can articulate why that would not be a good approach for a resection.
Yeah, I agree. I mean, well, not the best approach. There are some muscular attachments to the transverse processes. So that's not only is, in my opinion, that's probably more surgically disrupted than needs to be. I mean, you don't have to expose all those areas. It's also potentially impacting, so tougher recovery in big picture, probably a little bit harder. I mean, the transverse processes, there are more important parts of the body, but you don't want to disrupt anatomy if you don't have to. That's why, I try to anatomically restore the transverse process, and do a anatomic resection as opposed to disruption of more anatomy. The other thought process is as you get closer to the pedicle, the facet joint can live near there. So you can get a little bit too close, potentially if you're doing a complete transverse process resection at that junction, you can maybe start impacting the facet joint a little bit. So I wouldn't recommend that.
Okay, now I appreciate there's. Oh, Dr. Jenkins, sorry.
let me just say also, We see patients who what you're describing is an iatrogenic fracture, an iatrogenic meaning caused by the doctor, an iatrogenic fracture of the transverse process that can cause pain. And I've seen patients who have had that and have come in with pain that we've then had to fix or resect the entire transverse process because they have this floating bone that's now banging around. And now they've also lost the muscular attachments, as Dr. Haines, we want to preserve as much as possible. Yeah, I don't think that's a long-term solution. I think you see, especially in the international literature, there's a lot of people who describe a technique but don't have 5-year data on its outcome. So it's a great idea, but as I tell my residents, everything works in theory. Practice is something else, and you have to be cognizant that not every great idea you have is going to actually be in the patient's best long-term interest.
That makes sense. And like would the corrective surgery for this be an ALIF then, since you don't have the space to put in the pedicle screws for a posterior fusion approach?
You can still put a pedicle screw in. The pedicle's still there.
Yeah, it's not a pedicle resection, so you can still put a pedicle screw for sure.
Awesome. Well, thank you very much for your answers. I will cede the floor.
Thank you, Dr. Jenkins and Dr. Haines. Would you have time for one more question, maybe, for the person who has her hand raised for quite a while?
Sure.
Yeah. Mani Sunya, if I am pronouncing it correctly.
Yeah, thank you. Hi, good morning. Thank you, Dr. Haines and Dr. Jenkins. I think Dr. Haines knows my daughter is 2 months post her resection. And one of the things I'm finding frustrating, where we are from California, is how important the post-op and the PT is. And we are just not finding the support out here that we received at your clinic at VSI. That all the techniques are different. The physical therapists have no understanding of Bertolotti's and don't seem to even want to know or speak to the therapists in your facility. I'm just wondering if you have any guidance or advice, because I certainly want my daughter to make the most of her post-op therapy.
Well, I'll be calling them myself again after this discussion. So thanks for letting me know that. It is a less common treating condition. One of the things that I see that I make sure we get ahead of, and I'd be interested in hearing Dr. Jenkins' opinion on this, that I definitely noticed that when I do a resection, so I saw somewhere in the comments, basically, you've got this pseudoarticulation, you've got this big block of bone, and right in front of it is the L5 nerve. So what I see in my resections actually is good for everyone to know. I've never seen this be permanent, but I do have patients who have a post-operative, we call it radiculitis or nerve irritation. It typically kicks in after resection, 5, 7, 9 days in that point where people feel good right off the bat. And then they say, I've got back achiness. That gets better, but I still have a little bit of nerve discomfort going down the leg. That's why I love talking to therapists. So, my therapists know this, but when patients are traveling, we try to communicate with the therapists wherever they're from as well to prevent this L5 nerve tension. One of the common things we do to either prevent it or minimize it, it's called nerve glides, basically stretching the nerve, getting some mobility in there. Those are some unique things that I see with the resection. I think the big thing is the communication. One of the things that we try to do is get our patients to get, like you mentioned, PT in the facility, in our facility, who are by knowledgeable therapists before they go back home to a place that may not have the same quality. But there are a couple unique things that I think are paramount. And again, I'm glad you brought this up because I'll call them again and reiterate that to them, because it can be different therapists and they may not communicate.
Yeah, I think sometimes you just have to, if you're really not getting the treatment you need in place number one, you got to go find some place that will be more open to it and let them know you're coming to them specifically because the first place didn't take you seriously. And if they don't take you seriously, you're not going to go with them either. And so, that sometimes makes people stop and but to the point of just the general lack of knowledge, if you can get to somebody that makes your daughter better, excuse me, then they come back and they are essentially the ambassador of successful treatment of Bertolotti syndrome. And that makes some of the less Bertolotti's curious doctors, say some, more curious because, wait a minute, I didn't think this would work, but hey, this person went from being disabled to being abled. wait a minute, maybe I got to stop and think. So sometimes you have to go a little further afield to get the right treatment. But when you come back, you can re-inform all the people who gaslit you in the first place in an inviting, not shaming sort of way.
Thank you very much.
Yeah, and to add to this, I know it's very important to find also Bertolotti knowledgeable physical therapists. So I'm actually in contact with one of the physical therapists who has been treating people with EDS, CCI, and she mentioned that she's also treating Bertolotti syndrome. She's located in New York City, so I will have a meeting with her soon to see what she can do for our Bertolotti community. And so stay tuned because there might be another meeting coming up where I will be focusing on physical therapists and to help the community also in this way. So yeah, I think, well, okay, I don't want the person who has her hand still raising. Maybe one last question for the person that's called iPhone. Do you want to pose a question? Oh, maybe that hand was up for by accident. Okay, so I think we spent quite some time together. Thank you again, Dr. Jenkins and Dr. Haines. I've put in the chat the link to Dr. Jenkins's clinic and also Dr. Haines's website where you can do a consultation with them to get all your questions answered. If you are not yet in the Facebook group, the Bertolotti Education Facebook group, you can join it and post your question, and someone might have the answer already for you. So yeah, I would say Dr. Jenkins and Dr. Haines, thank you for joining. For those who still want to stay and chat, you can stay around. I will be on this call still. I will be stopping the recording right now.